Acute gastroenteritis.
Acute GE is specifically a diarrheal disease.
Okay, so it has to have diarrhea.
It has to. And we're looking for a quantifiable change. 3 or more loose or liquid stools per day. At least 200 grams of stool per day. It has to be a rapid onset, and it must last less than 2 weeks.
It's rarely just the diarrhea, is it? It's usually accompanied by, well, the greatest hits of misery.
Oh, absolutely. You've got the nausea, the vomiting, often a fever, and that cramping abdominal pain. You bet on the viruses every single time. Most cases of acute infectious gastroenteritis are viral.
And anyone in particular?
Specifically, Norovirus. It is the heavyweight champion. It's incredibly contagious, it hits hard, and it just spreads like wildfire in closed environments. Schools, cruise ships, hospitals.
Generally, the bacterial squad includes things like Staphylococcus aureus, that's your classic potato salad left out in the sun at a picnic, Campylobacter jejuni, Shigella, Salmonella, Yersinia, and of course, various strains of Escherichia coli.
And then kind of lurking in the background, you mentioned the parasites.
Right, Giardia and Cryptosporidium, these are the ones that tend to linger.
Viral GE, aside from just being the most common, it tends to have a shorter duration. It hits you fast and it leaves relatively fast. The patient might be a febrile, so no fever, or maybe just a low-grade one. Viruses can definitely burn hot. So don't fall into the trap of thinking high fever automatically equals bacteria.
Okay.
However, bacterial GE does typically present with a longer duration of symptoms, and yeah, higher fevers are more common. But the biggest differentiator, the real red flag that screams bacteria at you.
Let me guess. Blood.
It's the bloody diarrhea.
Yeah.
Dysentery. Parasitic GE has its own little signature. You'll often see mucus in the stool, maybe some blood as well. But a very specific symptom to ask about is perianal itching. Patient mentions that your mind needs to immediately think Giardia.
The general examination. What are we hunting for?
Well, vital signs are paramount, obviously. Tachycardia and hypotension tell you the tank is empty, that they're losing volume. But the absolute core of the exam is the diagnosis of dehydration.
Skin turgor.
The pinch test. You gently pinch the skin, usually on the abdomen or the back of the hand. In a healthy, hydrated person, it snaps back instantly.
And patient.
If it's delayed, meaning the skin remains elevated or tented for a second after you let go, that is a classic sign of significant fluid loss. The interstitial fluid is just gone. The elasticity is gone.
The second on the checklist, mucous membranes.
Right. Ask the patient to stick out their tongue. And don't just glance at it. Really look at the texture. Is it moist and pink? Or is it dry, rough, almost like sandpaper? That's a very definitive sign.
And the eyes.
Sunken eyes. This is a very specific, almost evolutionary sign. As the little fat pads behind the eyes lose their hydration, they shrink, and the eyes actually retreat back into the orbit. It gives the face a sort of gaunt, hollowed-out look.
And finally, the output.
Oliguria. You have to ask them, when was the last time you peed? If it's been, say, 12 hours, or if the urine they do pass is dark amber, the kidneys are holding on to every last drop of water they can because the body is in crisis mode. Guarding is that reflexive tightening of the stomach muscles when you press down because it hurts. It's the body trying to, create a shield. It's voluntary to a degree.
Okay.
But rigidity. Rigidity is a board-like abdomen. It's hard even when you aren't pressing. That implies peritonitis, inflammation of the entire lining of the abdominal cavity.
And that is not medical GE anymore.
Not at all. That is a surgical emergency.
We're talking about a burst appendix, a perforated ulcer, something like that?
Yeah, right. The alarm symptoms. If a patient has any of these, your threshold for admitting them to the hospital goes way, way up.
We've already mentioned severe dehydration and bloody stool. What else is on that list?
Severe abdominal pain. If your patient has been hospitalized or has used any antibiotics in the past 3 to 6 months, you must consider Clostridioides difficile infection. Stool studies are not routinely necessary for straightforward viral gastroenteritis, which, remember, is the vast majority of cases.
Why not?
It's expensive, it's slow, and most importantly, it doesn't change the management. We tell them to hydrate and rest either way.
So when do we actually order them?
You order them if there are red flags. Persistent fever, signs of severe dehydration, blood or pus in the stool, or if the diarrhea has lasted for more than a week. Basically, if it's weird, scary, or chronic, you test. If it's simple and acute, you treat them empirically. The only thing that needs emergency treatment is dehydration. Everything else, the nausea, the pain, that's all secondary to getting fluid back into the vessels.
And for fluid choice, assuming they can't keep oral fluids down.
It's IV fluids, and the notes here say Ringer solution is preferred over normal saline.
Why is that? I feel like saline is usually the go-to workhorse.
Saline is fine, it works, but Ringer's lactate more closely mimics the electrolyte composition of our own blood. It also has lactate in it, which acts as a buffer that helps correct the metabolic acidosis you often see when you're losing a lot of bicarbonate through diarrhea. The question is, why does the stomach hurt so much in GE? It's colic. The intestines are squeezing violently, what we call hyperperistalsis, basically trying to push the infection out. Antispasmodics work by relieving that smooth muscle contraction. They just tell the gut to relax a little bit. The classic generic here is hyoscine. It's an anticholinergic, which means it blocks the nerve signals that tell the muscle to cramp up. You will probably recognize this under the famous trade name Buscopan. It comes in a 20 milligram ampoule for injection.
And the second generic that's listed?
That would be timonium methyl sulfate. This is another antispasmodic agent. The trade names listed here are Visceralgine or Spasmofree. Both come as 5 milligram ampoules. Spasmofin is indeed a heavy hitter. It's a combination of hyoscine, the relaxant we just talked about, and ketoprofen.
What's ketoprofen?
Ketoprofen is a potent NSAID, a non-steroidal anti-inflammatory drug, like a stronger ibuprofen. So you're relaxing the muscle and killing the inflammation. It attacks the pain from 2 different angles. And this is important, it is intramuscular, or IM only.
What happens if you accidentally put it in an IV line?
Oh, that would be bad. It can cause severe tissue damage and phlebitis, which is inflammation of the vein. Ketoprofen is just really harsh on the lining of the vein. You never, ever give it IV.
Now for the vomiting. The antiemetics. Again, let's categorize these by their mechanism.
Right. We have 2 main players in the injectable category here. First, we have the dopamine antagonists. The generic you'll know is metoclopramide.
How does that work?
This drug works by blocking dopamine receptors in the brain's chemoreceptor trigger zone, which is basically the vomiting center. It also speeds up gastric emptying. It's prokinetic, so it helps push everything down and out. The classic trade name is Primperin, which comes as a 10 milligram ampoule.
And this second mechanism?
That would be the serotonin receptor blockers, specifically the 5-HT3 antagonists. The generic here is ondansetron. This is the gold standard for chemotherapy-induced nausea, but it works great here too.
And the trade names for ondansetron?
The trade names listed are Zofran and Dansette, both available as 8 milligram ampoules. You should avoid giving Primperin as a rapid, direct IV injection, a fast 5E push.
Why? What does it look like if that goes wrong?
It can cause what we call extrapyramidal manifestations. Because it blocks dopamine, it can accidentally mess with the motor control centers in the brain, the same areas affected in Parkinson's disease.
And what does the patient experience?
The patient might suddenly become incredibly restless, agitated. They can start having involuntary muscle movements, spasms of the face, neck, or tongue. It's called a dystonic reaction.
That sounds absolutely terrifying for a patient who just came in for a stomach bug.
It's a complete nightmare. Sometimes they get an oculogeric crisis where the eyes roll back in the head. The rule is simple. Infuse it slowly, dilute it in maybe 50 cc of saline, and run it in over 15 minutes. Never ever give strong analgesics for colic until you have firmly excluded an acute abdomen.
Diagnosis before masking the symptoms.
Exactly. If you mask the pain of a bursting appendix with strong painkillers, the patient feels great. They might even go to sleep. And then the appendix bursts and they wake up in septic shock. You need that pain as a diagnostic guide until you know for sure it's safe. The vast majority of GE cases are viral and will improve on their own in 7 to 10 days with just supportive care.
So indiscriminate antibiotic use is a complete no-go. When do we pull the trigger?
The main indication is bloody diarrhea or dysentery. This is typically caused by invasive bacteria like Shigella or Salmonella.
Drug class A is the quinolones. What's their mechanism? How do these work?
Quinolones are fascinating. They primarily focus on gram-negative bacteria. They work by targeting an enzyme called bacterial DNA gyrase, which basically stops the bacteria from being able to replicate its DNA. It snaps their reproductive cycle.
And the big generic here is?
Ciprofloxacin, usually in a 500 milligram tablet.
And the trade names for our listeners using these charts?
We have Ciprofar, Servaflox, and Ciprobay.
And what's the typical dosing?
The standard dosing context is 1 tablet every 12 hours for about 5 days. The absorption of ciprofloxacin is heavily affected by calcium.
So no taking it with a glass of milk?
Absolutely not. The calcium binds to the drug molecule in the stomach. It forms this thing called a chelating complex. Think of it like a little magnet snapping onto the drug. The body can't absorb that complex. It just passes right through you.
So you lose the effect of the drug?
Completely. You have to advise patients to take the pill at least 2 hours away from milk, yogurt, cheese, or even calcium-fortified juices. It's a crucial counseling point.
It really is. There is another quinolone listed, levofloxacin.
Yes, generic levofloxacin, 500 milligram. The trade names are Tavanic, Tavocin, and Lavoxin. The main advantage here is the dosing. It's just 1 tablet daily for 5 days, much better for patient compliance.
And the calcium rule.
Still applies, same mechanism.
Okay, moving to drug class B, sulfonamides.
Right. The generic combination here is sulfamethoxazole plus trimethoprim. The classic trade name that everyone knows is Septrin DS or Bactrim. Dosing is typically every 12 hours for 5 days.
Is there a specific warning for this class of drug?
A huge warning. Sulfa allergies are very common and they can be incredibly severe. They can range from a simple rash to Stevens-Johnson syndrome, which is a life-threatening skin detachment condition.
Wow. So what do you tell the patient?
You must warn the patient explicitly. If you develop any kind of rash, itching, or have difficulty breathing, stop this medication immediately and call us.
Okay. Lastly, for antibiotics, the source lists injectables for severe cases.
These are the 3rd generation cephalosporins. We are talking about ceftriaxone, usually 1 gram. The trade names listed are ceftriaxone, Sandoz, and Wintriaxone.
And the other one?
The other is cefotaxime, also 1 gram. Trade names Cefotax and Cloforin. Ceftriaxone is usually given once daily for 3 days, either IV or IM. But the safety note here is absolutely non-negotiable. Never prescribe these injections for a patient to take outside a hospital setting without doing an allergy test first.
The risk is anaphylaxis.
Exactly. Anaphylaxis to cephalosporins can kill in minutes. If they are at home, you stick to pills unless you have nursing support who can do a test dose first. You do not want a patient going into shock in their living room. For the vomiting, we use prokinetics. The first generic is domperidone. The trade names listed are Motilium, 10 milligram, or Gastromotil. Dosing is usually 3 times daily until the vomiting stops.
And what's its mechanism?
It works by tightening the sphincter at the top of the stomach so food doesn't come back up, and relaxing the exit, the pylorus, helping food move down the right way.
Next on the list.
We have Mosapride. Trade names are Fluxapride or Mosapride, 5 milligram. And then Itopride, with trade names Ganeten or Itopride, 50 milligram. These are newer prokinetics. They target specific serotonin receptors to keep the gut motility coordinated and moving forward.
And for the patient who literally can't swallow a pill without throwing it right back up, the source is a really clever option here.
Yes, this is a game changer. It's ondansetron again, but in an orodispersible film, the trade name is Ondulence, 8 milligram.
So it just melts on the tongue.
Exactly. You just place the little film on their tongue and it dissolves instantly. It gets absorbed right into the bloodstream through the oral mucosa. It's perfect for severe nausea at home where you don't have an IV line.
That's brilliant. What about the cramps?
For that, we use the oral antispasmodics. We are basically back to the oral versions of what we used in the ER. So Buscopan, 10 milligram tablets, Nuspasm, Spasma-Free, or Visirogene. Standard dosing is 3 times daily until the cramps subside, but you absolutely must avoid antidiarrheals if there is bloody diarrhea or a high fever that suggests an invasive bacterial infection.
Why? I mean, it seems counterintuitive. If I'm sick, I want the symptoms to stop.
I know, but you have to think of the diarrhea as a protective flushing mechanism. The body is desperately trying to expel the bacteria and the toxins they produce. It's a defense strategy. If you give a drug that paralyzes the gut to stop the diarrhea, you are essentially trapping those pathogens and their toxins inside the body. We call this preventing the washout of GIT toxins.
Yeah.
It can actually worsen the infection, leading to things like toxic megacolon or systemic toxicity.
So the rule is?
The rule is, if it's simple, watery, viral-looking diarrhea, fine. A drug like Antinol can help with comfort. But if it's bloody dysentery, absolutely not. You have to let it flow.
Very clear. Now, fever control. We all know paracetamol. The trade names listed here are Abimol, Paramol, Panadol Advance, Adol, all 500 milligrams. But I want to zoom in on a specific detail in the text. It says paracetamol is safe for cirrhotic, so liver disease patients up to 2 grams per day.
When you take paracetamol, most of it is metabolized safely by the liver through normal pathways. But a small fraction, maybe about 5%, is turned by the cytochrome P450 system into a very toxic metabolite called NAPQI. In a healthy person with a healthy liver, a superhero molecule in your liver called glutathione comes along instantly. It neutralizes NAPQI, turns it into something harmless, and you just pee it out. No problem at all.
But in an overdose situation,
In an overdose or in someone who is a chronic alcoholic or a patient with severe liver disease, your glutathione stores get depleted. They just run out.
so the superhero's gone.
The superhero is gone, and the villain, NAPQI, builds up. And NAPQI is nasty. It binds directly to the liver cells themselves and causes necrosis. It kills them. That is hepatotoxicity in a nutshell.
So the 2-gram limit for liver patients.
The 2-gram limit is the safety buffer. Even a damaged liver usually has enough glutathione to handle up to 2 grams of paracetamol a day without running out. But if you go over that, you risk hitting that depletion point where the glutathione runs dry and the NAPQI takes over.
Finally, Section 6, diet and lifestyle. I, like many people, grew up on the brat diet. Bananas, rice, applesauce, toast. Is that still the law of the land?
I'm sorry to be the one to destroy your childhood, but no, the sources are very clear on this. The brat diet is no longer recommended.
Why? It's so bland and comforting, it feels right.
It does feel right, but it's nutritionally terrible. It's almost entirely simple carbs and sugar with very little protein, fat, or micronutrients. It does not support rapid recovery because your body needs energy and protein to fight the infection and to repair the damaged gut lining.
So what is the correct regimen then? What should we be telling patients to eat?
Hydration is number one, always. Water, clear soups, diluted juices. But for food, a modern advice is to eat a balanced, regular diet as tolerated. If you feel like you can eat chicken, eat chicken. If you want potatoes, eat potatoes.
Are there any restrictions at all?
Yes. There are 3 things to avoid. Avoid high-sugar foods, which can pull more water into the gut via osmosis and make diarrhea worse. Avoid high-fat foods, which are hard to digest and can slow stomach emptying. And definitely avoid dairy products for a few days.
Why dairy? Is that a permanent ban?
No, it's just temporary. During GE, the brush border of your intestine, that microscopic lining that kind of looks like a shag carpet, it gets damaged and sheared off by the virus or bacteria.
And that's important because
That brush border is exactly where the enzyme lactase lives.
the enzyme that digests lactose, the sugar in milk.
Right. So for a few days, you become temporarily lactose intolerant. If you drink milk or eat ice cream, you can't digest the lactose. It just sits there, it ferments, it causes gas, bloating, and more diarrhea.
Transient lactose intolerance. That explains so much about why ice cream is a terrible idea during a stomach bug.
A very, very bad idea. You just need to give the gut a few days to regrow that lining before you reintroduce the latte.
delayed skin turgor.
ودي سببها إيه؟
سببها إن الجسم ذكي بيسحب المية من الأنسجة الأقل أهمية زي الجلد عشان يحافظ على الدورة الدموية والأعضاء الحيوية. العلامة التانية هي جفاف الأغشية المخاطية، يعني تلاقي اللسان جاف تماماً.
تمام.
نفس المبدأ، الجسم بيقلل إفراز اللعاب عشان يوفر كل نقطة مية. العلامة الثالثة هي غور العينين أو sunken eyes، والرابعة هي قلة كمية البول oliguria. نظام برات، الموز والرز والتفاح والتوست، إن قيمته الغذائية محدودة جداً. هو ممكن يقلل عدد مرات الإسهال، لكنه مش بيدي الجسم البروتين والسعرات اللي محتاجها عشان يصلح الأنسجة التالفة في الأمعاء. بس نتجنب الحاجات اللي ممكن تهيج المعدة زي الأكل الدسم أو السكريات العالية أو منتجات الألبان في الأول.